So BTK inhibitors have been classically developed as continuous therapy, and the current standard of care is not to stop, but to continue as long as it works, as long as the patient can tolerate without toxicity. But if the toxicity develops, then there is an FDA package insert that guides the dose reduction and dose discontinuation eventually. So I want to first highlight that it's not standard to stop the BTK inhibitor in the current era. However, there are limitations of continuous BTK inhibitor therapy and a rising interest to develop a time-limited regimen in CLL. One example is to combine BTK inhibitor with BCL2 inhibitors and monoclonal antibody, making into a triplet therapy, induce a very deep response such as undetectable MRD and stop the therapy at that time. The other approach is to use a BTK inhibitor with a BCL2 inhibitor without the antibody, so a doublet regimen, and then stop after a fixed duration or after the achievement of undetectable MRD. So the field of CLL is definitely moving forward to test the time-limited regimen in CLL. I think the big question is that without BCL2 inhibitor incorporated to the regimen, can BTK inhibitor discontinued? And one of the key things that many people feared, including myself, the providers, and the patients, was that the disease can flare after removing the BTK inhibitor. And it has been well reported by others that a pseudoprogression or accelerated CLL can occur if BTK inhibitors are stopped too quickly early on in the treatment course. So therefore, many people had feared the stopping of the BTK inhibitor therapy. However, that phenomenon seems to apply more to the high burden state when the disease can proliferate more actively and resynthesize BTK more actively than before. After a certain period of time, actually disease burden goes down with BTK inhibitor therapy and the BTK resynthesis rate is much lower, and therefore stopping the BTK inhibitor therapy can be feasible at that time. We do not yet know when that time is, and there are many clinical trials prospectively looking into that question. For instance, the French Philo group has launched a randomized phase 2 study comparing continuous acalabrutinib versus 18 months of fixed duration acalabrutinib therapy. So that would be one interesting approach. There are several other single-arm phase 2 studies combining a BTK inhibitor with a monoclonal antibody, induce a good quality of response, and stopping the therapy either at 1 year or 2 years of BTK inhibitor therapy. So more questions to be answered moving forward.